arrhythmias. So these there are also advanced therapies which can be offered to these patients in addition to medical therapy. And so I will present a case of this atrial fibrillation ablation using intracardiac echo in a congenital heart disease called Tritriatum sinister. Tritriatum sinister is basically there's a membrane which is dividing the left atrium. It is a congenital condition. Most of it may be an obstructive or non-obstructive. Most of the obstructive cases present in early infancy and it has high mortality, but some of the non-obstructive cases may progress to adulthood and they do not have uh, uh, significant mortality, but may have atrial fibrillation or may present with stroke because of atrial fibrillation or some clotting on the membrane. This was a 35-year-old male patient who has a symptomatic drug-refractory atrial fibrillation and no other comorbidities. Baseline, it was an insufficient AF. This was the X-ray. Cardiac size was literally normal. On echo, you can see there is a membrane in the left atrium, which is dividing the left atrium into a superior and an inferior chamber. The superior chamber is containing all the four pulmonary veins, and it is a non-obstructive type. There are multiple fenestrations in the membrane. So, like when you have a when you do AF ablation, you have to do a transeptal puncture, and then you have to go to the pulmonary veins. So, in this case cannot be done without intracardiac echo because to do a transeptal puncture above the membrane, you have to know the exact location of the membrane, see the membrane, and then reach out to the pulmonary veins to do a pulmonary vein isolation. So all the cases of AF ablation, we do a pre-procedure CT scan to know what exactly is the morphology, and we fuse the CT scan in our cath lab to the electroanatomical map, so, which also give a broad view of the anatomy, and also we have to map less area. So this was a baseline. The patient was in incessant AF. This was the intracardiac echocardiography. Like you can see, there's a membrane in the left atrium, and with intracardiac echocardiography, we can get a precise 3D anatomy. We can also get an accurate location of the membrane. And with cartosound, we can do a detailed electroanatomical map also simultaneously. So this is the membrane. So like you can see, this is the fossa ovalis, left atrium. This is a membrane. This is the left atrial appendage, and this is the pulmonary veins. So gradually, when you go to the right atrium, you have to rotate this probe so that you see the various structure, and we use it to do a transeptal puncture above the membrane, because if we do a transeptal puncture below the membrane, then the catheter will be stuck and we will be in problem. So when you go to 2 to 7 o'clock, like you will see the various structures, like you will see that this I have labeled for you. This is aorta, pulmonary artery, RA, RV at 2 o'clock. Then as you go further, 3 o'clock, these are the structures. You see the membrane dividing the left atrium. The pulmonary veins are above the membrane and appendage is below the membrane. So you can see the pulmonary veins and also the important structure which we need to take care of is the esophagus, which is just posterior to left atrium. So while ablating in left atrium, we can damage the esophagus, which can lead to life-threatening complications of because of esophageal injury. There can be fistula there. So we use continuous temperature monitoring or to prevent the injury. So with eyes, like we can do mapping, we can do transeptal puncture above the membrane. So our first step is to do a pulmonary vein isolation. So we did a successful pulmonary vein isolation. By successful pulmonary vein isolation, we means there's an entrance as well as exit block. So no arrhythmogenic impulse can exit from pulmonary veins to left atrium, and also there is no impulse can, if we pace the left atrium, can affect the pulmonary veins. So this is entrance and exit block, which are the endpoints of pulmonary vein isolation. But the AF persisted even after successful pulmonary vein isolation, which can occur in congenital heart disease, those who have abnormal substrate, abnormal left atrium. And then we did a cafe mapping. So in between a ridge between this pulmonary vein and appendage, we could, after ablating there, we could restore it to sinus rhythm. And this is the post-operative procedure voltage match. To summarize, like this was a case of TRIATRIATUM. We use eyes to do a successful transeptal puncture and to navigate our case, and then after successful PVI ablating a cafe, we could ablation, we could achieve sinus rhythm. The patient is asymptomatic since nearly now 1 year on medical therapy. So this was the case. Thank you. So we take a break for 2 minutes, and then again, I think we announce the name.